All right, today we are diving into one of the most important skills you'll ever use in nursing, mastering sensory alterations. And let me tell you, this isn't just some textbook theory. This is about patient safety, their comfort, and their recovery. Getting this right is absolutely non-negotiable.
So picture this. You're in the middle of a busy ICU shift, and your patient, who was fine an hour ago, is suddenly agitated and confused. What's going on? Is their brain just getting bombarded with too many alarms and lights? Or are they so isolated that their mind is basically creating its own reality? It's a tough call, right? Well, by the end of this, you're going to have the framework to solve this exact clinical puzzle.
To even begin to solve that puzzle, we have to start with the fundamental science. Before we can figure out what's going wrong with the patient's senses, we need a really clear picture of how they're supposed to work in the first place.
You know, every single thing we sense, whether it's a sight, a sound, a touch, it all follows this simple three-step chain reaction. First up is reception. Some kind of stimulus, like light, hits a nerve receptor. Simple enough. Second, you've got perception. That signal zips up to the brain, which then has to figure out what it all means. And finally, number 3 is reaction. The brain makes a decision. Does it respond to this, or, and this is just as important, does it ignore it and just file it away as background noise?
Now, what's so fascinating is the brain's incredible ability to adapt. It literally learns to ignore the feeling of your watch on your wrist or the constant hum of a refrigerator. But, and this is a big but, there is one crucial exception it will never ever ignore, and that's pain. Pain is a vital warning signal, so the brain just won't tune it out. You gotta remember that.
So, when this sensory system breaks down, it usually swings to one of two extremes. On one side, you have sensory overload. Think about that ICU again. Constant alarms, bright lights, people talking. The brain just can't filter anything out, and it leads to racing thoughts and really severe anxiety. Then on the other side, you've got sensory deprivation. Picture a patient in a quiet, lonely isolation room. In this case, the brain is so starved for input that it can actually start generating its own, leading to boredom, panic, and sometimes even full-blown hallucinations.
Okay, so that brings us to assessment. As nurses, we're basically clinical detectives, right? We're always on the hunt for risks that could mess with a patient's sensory world. And that includes everything from their age to the medications they're taking.
And speaking of medications, there is a massive red flag you always have to be watching for: ototoxicity. It's a fancy word, but it just means that certain drugs can literally be poisonous to the auditory nerve in the ear.
Now, for your exams, and more importantly, for your patient's safety, you have to know these drugs. We're talking about the aminoglycoside antibiotics. Specifically, look for the ones ending in mycin. Think streptomycin, gentamicin, and tobramycin. These carry a really high risk of causing permanent hearing damage.
So here's the bottom line, the critical point. If your patient is on one of these antibiotics and they suddenly start complaining about ringing in their ears, that's tinnitus, your internal alarm bells have got to go off. That is a classic sign of toxicity, and it needs to be evaluated immediately.
And it's not just about meds. Normal aging completely changes our sensory landscape. Take a look. After age 40, the lens in your eyes starts to stiffen. After 30, you actually start losing the ability to hear high-pitched sounds. And after 60, our sense of where our body is in space, that's called proprioception. It starts to decline, which dramatically increases the risk of falling. Each one of these changes demands a very specific nursing action from us.
So, now that we know how to assess for these problems, let's talk about what we do. Let's talk about intervention. And we'll start with one of the most vital nursing skills there is, breaking through those communication barriers that are created by sensory deficits.
Okay, let's talk aphasia. After a stroke, this is really common, and it's critical to know the two main types. First, with expressive aphasia, the patient understands you perfectly, but they just can't get the words out. So what do? The best thing is to use picture boards or ask simple yes or no questions. Then you have receptive aphasia. This is kind of the opposite. The patient can speak, sometimes fluently, but they can't understand what you're saying to them. So in this case, we have to use short, simple sentences and gestures. All right, I need your full attention for this one, because this is probably the single most common mistake people make when talking to someone with a hearing deficit, and it is a rule you must never, ever break. Do not shout.
And here's the science behind why shouting is such a bad idea. When you shout, you naturally raise the pitch of your voice. Well, age-related hearing loss, that's presbyacusis, it causes people to lose the ability to hear high-frequency sounds first. We're talking about those sharp consonants like T, S, and F. So by shouting, you are literally making yourself harder for them to understand. Instead, what you want to do is face them, speak slowly, and actually lower the pitch of your voice.
Okay, let's shift gears to implementation. Once we've assessed the deficit and we know how to communicate, our very next priority is to create a safe environment to protect our patients from any harm.
When you're walking with a patient who's visually impaired, you have to use what's called the sighted guide technique. It's just 4 simple steps. 1. You offer your arm. 2. You have the patient grasp your arm just above the elbow. This is key because it allows them to feel your body's movements. 3. You walk just a half step ahead of them. And 4. You basically become their eyes, verbally announcing any upcoming hazards like stairs or doorways.
And here's another absolute rule for safety. Once you have oriented a visually impaired patient to their room, you must never, ever move the furniture. They literally create a mental map of their space by touching objects and remembering where things are. Moving a chair is like creating an invisible wall for them, and it's a huge fall hazard.
Now, let's talk about a different sense, touch. For our patients with peripheral neuropathy, the ones who can't feel their hands or feet properly, something as simple as a bath can be incredibly dangerous. And this brings us to the water heater rule. This is so important. You have to teach these patients and their families to set their home's water heater to a maximum of 120 degrees Fahrenheit, which is about 49 degrees Celsius. Anything higher than that can cause a catastrophic burn before the patient even realizes they're hurt. This number is an absolutely critical, testable safety standard.
And to prevent these thermal injuries, there are 2 more key rules. First, these patients should never use heating pads, ever. They can cause deep tissue burns without them feeling a single thing. And second, color-coding the faucets, red for hot, blue for cold, gives them a crucial visual cue to make up for their lost sense of touch.
At the end of the day, our ultimate goal is always to restore function and promote dignity. And this means adapting those activities of daily living, or ADLs, so that our patients can care for themselves as much as humanly possible.
Here's a simple but absolutely brilliant technique for promoting independence during meals. It's called the clock method. You just arrange the food on their plate as if it were a clock face, and you tell the patient what's where. So, for example, hey, your chicken is at 12 o'clock, and your vegetables are at 3 o'clock. It's so simple, but it empowers them to eat on their own.
And we can adapt other ADLs too. For a patient who has weakness on one side, you always teach them to dress their affected, weaker side first. It just makes the process so much easier. In the bathroom, installing grab bars that are a different color from the wall, high contrast, makes them way easier to see and grab, which helps prevent falls.
So, let's lock in the most important takeaways from all of this. You absolutely must be able to tell the difference between sensory overload and deprivation. You have to know expressive versus receptive aphasia. You need to master that sighted guide technique. And for tactile safety, that 120-degree water heater rule is non-negotiable. Look, mastering these concepts isn't just about passing an exam. It's about being the nurse who can step into that ICU room we talked about at the beginning and know exactly how to start restoring your patient's world.